teaching us the art of deduction, elimination, and diagnosis of the unusual, Sherlock Holmes, an image from a diagnostic physician, tonight on Call with the Prairie Doc.
Starting this season, we are offering a Facebook Live option for our viewers to still be able to watch the show during the regular broadcast times on Thursday nights and ask questions. All you need is either your laptop, tablet, or a mobile device, such as your smartphone, to view the show. Here's how to do that. First, log into your Facebook account. If you don't have a Facebook account, go to facebook.com and complete the information to create an account. In the search bar, type in Prairie Doc. Make sure to click like on our Facebook page so you can get updates and notified when we are going live. Each Thursday on the Prairie Doc's page, you will be able to see a live broadcast of the newest episode. You can also ask Dr. Holm questions via Facebook Live. All you have to do is ask your question in the comment bar and await a response. If you miss a show live on Facebook, it will be available later both on the Prairie Doc Facebook site or at prairiedoc.org.
Good evening and welcome to On Call with the Prairie Doc. Most of us love to solve puzzles, and if that solution solves a crime or mystery, even better. The skills illustrated in the Holmes stories transfer to the mysteries of medicine exceptionally well. First, let's investigate this week's Prairie Doc quiz question. Now, it's tricky. True or false? The stories penned by Arthur Conan Doyle about Sherlock Holmes during the period 1880 through 1914 describes a private detective and best friend Dr. John Watson, narrator of most of the stories. True or false? Viewers who call in the correct answer will be entered into a drawing to win a signed copy of our book, The Picture of Health. Each of my essays originally written for this show comes with a wonderful accompanying photograph by Dr. Judith Peterson. We'll announce the answer and the winner at the end of the show. But remember, you only have 10 minutes to get your answer in for that quiz question. But all night long, we'll answer your medical questions about Sherlock Holmes and any unusual diagnoses as they're called in or sent to us via Facebook or email. Call in questions to 1-888-376-6225 or send us an email to the address on the screen. Remember, if you've got a case that you can stump the stars, then it's a winning opportunity. Joining us in the studio tonight is Dr. Henry Travers, a clinical professor of pathology at the USD Sanford School of Medicine in the Anatomic and Clinical Pathology Department. And joining us from Alabama via Skype is Dr. Robert Centor, who is with the University of Alabama at Birmingham School of Medicine as the Associate Dean of the Huntsville Regional Medical Campus and a professor of medicine in the Division of General Internal Medicine. He's world-renowned in his knowledge and his base, and I think he's even been involved with Cecil's Textbook of Medicine. Welcome, gentlemen. Let's start with you. Bob, let's start with you. Did I say that right? Is it Cecil's Textbook of Medicine?
I don't think so, but I've written a bunch of stuff, so.
Been in a variety of places. So
right. And I have to correct you. I actually recently retired as dean of our regional campus, and I'm enjoying the semi-retirement life.
Maybe it's Harrison's Textbook of Medicine out of Alabama. Is that right? Where is that?
Tinsley Harrison is revered in Alabama. He was the dean and the chairman of medicine, and really put us on the map.
So,
what's that?
Bear Bryant is revered more or less?
Bear Bryant is prayed to.
So there we know where it really is. That's a good one.
Yeah.
Pete, you're a South Dakota boy. Where did you grow up?
Well, actually, I'm not. I'm a South Carolina boy who got transplanted to the Midwest in the 1970s.
Oh, and a woman brought you here?
No, a job teaching at the University of Kansas at first.
And then what got you into medicine and then pathology?
Well, medicine was something my father did, something I was always interested in.
Oh, your dad's a doc.
Got sidetracked a little bit in chemistry in college, but then got back into medicine and went to a brand new medical school, Penn State, at the time in 1967. And the field of medicine was so broad that there was only one specialty, just one,
which is?
That would cover it all.
Yes.
And that's pathology.
Oh, I thought it was internal medicine.
No. Internal medicine has a great deal of difficulty with people like surgeons.
Yeah.
You know, urologists.
Yeah.
Things like that.
Yeah.
But pathologists interact with interact across the spectrum of disease and across the spectrum of patients.
Okay. And you know, we always think of you pathologists as people working in the morgue. And back in the days when you started as a pathologist, what percentage of what you did was in the morgue?
That was pretty common. When I first started, I was in the morgue daily. These days, it would be rare for me to be in the morgue once a week.
So it's a lot less.
Much less.
That's a pity. And it's a trend that came out of, I think, money. Payment.
Well, money has something to do with it, and certainly nowadays pathologists are loath to do anything unless they get paid for it. It used to be a service that the hospital rendered,
Yes.
and the hospital would, quote, pay the pathologist in order to do the autopsy. That was always a myth. It never actually occurred. Money never changed hands. But the pathologist today, because of the time commitment to do an autopsy, 4 or 5 hours sometimes to do the autopsy itself, and then another 4 or 5 hours looking at slides, and another couple of hours putting the case together.
That's a lot of work.
That's a lot of work.
Yeah. And I think the payment is not commensurate with the value and the of the service.
It never has been, but it's all for me and for a number of pathologists, possibly of the old school.
So why do you think that I invited you to be on this show about Sherlock Holmes?
Because you know I love puzzles.
Yes. You know, I've observed you doing autopsies, and we've worked together in many cases, and I see you as one of the great old style, not old, you're a young guy, old style thinker. But Dr. Centor, why do you think I would have invited you to be on this show?
Because you needed someone with a very classy accent.
That's
Amen.
Amen. That's it. No, it's because you and I met in our internal medicine organization, the American College of Physicians, and you are well known across the country, particularly with the med students, on your clinical acumen.
Well, I love medicine.
So tell us about your particular, you are named for what?
So when I was a very junior faculty member, I did a study trying to predict whether or not young adults and adolescents who came to our emergency department with a sore throat had strep or not. And the study that I published with my colleagues, people kept on reproducing it, and all of a sudden in the year 2000, I saw my name being used to describe the score that we use to stratify people.
So just real quickly, summarize that score.
Yeah, so if there are 4 factors, and the more of these that you have, the more likely you are to have strep. And then after I tell you that, I'm going to tell you what we've learned since then. The factors are tonsillar exudates. That's pus on the tonsils. If you look in your throat and you have a bad sore throat, you can actually see white stuff, and that's disgusting, and it's pus. Anterior cervical adenopathy. That means you have lymph nodes in your neck that are tender and palpable. You can feel them. The lack of a cough. People with a cough and sore throats are more likely to have a virus, and a fever. And it doesn't matter whether the fever is in the ER, in the doctor's office, or you had the fever last night. If you have a fever, you have a fever.
And the things that have been added to that since your paper.
So originally we were just trying to figure out if someone had strep or not. More recently, we've learned that there are other bacteria that can cause significant sore throats, especially in the 15 to 30 age group. So the classic strep throat is something called group A strep. And when you get a rapid test at the doc in the box, what they're doing is they're testing to see if you have group A on your tonsils. There's also group C that can cause tonsillitis, pharyngitis, sore throats that can lead to abscesses. And then just in the last 15 years, we've learned that there's a very difficult to grow anaerobic bacteria. And anaerobic means it does not grow with oxygen around. And so it's much harder to culture. And very few people can culture it. The name of it is Fusobacterium necrophorum. It's a fancy name. The importance is that it can cause abscesses and cause a very, very lethal disease called Lemare syndrome. And I can tell you a story about Lemare syndrome if you want to hear it.
I'd love to hear it.
So Lemare syndrome is, again, a disease mostly of the 15 to 30-year age group. It follows a sore throat. What's interesting about these sore throats is most sore throats get better in about 3 to 5 days.
Whether you treat them or not. I mean, antibiotics or not.
They're going to get better. If they have strep and you give them penicillin, they might get better a day or two faster, but they're going to get better in 3 to 5 days. The people who end up with Lemares, the sore throat keeps getting worse, and then they have something called rigors. And rigors is what is a fancy doctor name for a shaking chill. That's a sign that there's bacteria in the bloodstream. And what happens is the bacteria goes from the tonsil, it goes towards the jugular vein. And it lodges in the jugular vein, and for some reason this bacteria causes a clot to form, but it's an infected clot. That clot throws off little pieces. The doctor name for that is emboli, most often in the lungs, but it can also go to the brain, it can also go to the liver, it can go to the joints. It's a very bad disease. Over half the people who get this end up in the ICU for an average of about 7 days. About 5% of the people who get this die. And these are people who are totally healthy. It happens a lot in athletes. It does not happen in people who have some kind of an other underlying disease. It's a brutal disease, and so the last 10 years I've really focused all of my research and all of my writing on trying to figure out how to prevent this disease.
You know, what you say about rigors is that something that I experienced when I was sick with an infected stent in my biliary tract after pancreatic cancer diagnosis. And basically it's sepsis, like you say. There's an infection in the bloodstream, and that is terribly dangerous. And there's a lot said right now about appropriate and very quick treatment of sepsis, and we can talk about that. But when people get shaking chills, folks, do not delay. Now, I mean, chills are one thing, but shaking chills, get thee to the emergency room. And I want to do a roll-in. One quick comment, Pete, about what we just said?
Well, one of the things that Dr. Centor's work has done has contributed to a marked decrease in the complications that take place from Group A strep. Very uncommonly now do we see strep-related cardiac disease, and glomerulonephritis is, although not eradicated, it's
kidney.
much less common. Yeah, a kidney infection is much less common than it used to be, which are the primary reasons for wanting to treat strep in the first place, identify it and treat it.
Right. The character Sherlock Holmes had a gift for deductive reasoning in order to solve crimes. In fact, the medical field changed as a result of that sleuthing.
He was an MD medical doctor, studied up in Edinburgh, Scotland, and his mentor, who he worked under, was Dr. Bell. And Dr. Bell impressed Watson as in Doyle,
Yes.
as his powers of observation. He'd have a patient come in, and by looking at the patient, he could give an almost total diagnosis.
Where he came from, how far he walked, the whole nine.
Yeah, and the medical aspect of that got his mind going on that,
Right.
and how to expand it. This would drive Dr. Watson absolutely bonkers. If he was bored, he would inject himself with a solution of 7% cocaine to numb the mind or whatever. But if he was in a case,
Didn't need it.
didn't need it.
And Watson, he was.
Well, Watson, from hints in the stories, he was probably an alcoholic. He was a womanizer. He went through at least 2 wives.
Oh.
But it's not highlighted, but there are those little hints.
Right.
At one of the conferences that the Norwegian Explorers puts on, the gentleman who was head of the Pennsylvania Blue Cross Blue Shield gave a paper explaining how Holmes and Watson were codependents
Oh.
and how they each would aid the other's habits. He led to some modern thinking about how to analyze. And as a doctor, you have a patient come in, you have to analyze the symptoms. Then from the symptoms, you have to do a process of elimination to hopefully arrive to a
Correct diagnosis.
diagnosis. And when you eliminate everything else, whatever remains has to be the answer. Holmes finds clues about poisons from observing certain things on the victim. He finds clues. He wrote a monograph, a booklet on the characteristics of cigar ash, how to identify cigar ash. That's the kind of brain he had. And of course, he also was into bees.
He was into bees.
Yes, he's now retired. By the way, we can prove that Sherlock Holmes is still alive.
Oh, we can?
Yes. Anybody who is anyone in British society, when they die, the obituary is printed in the London Times. They have never printed his obituary, therefore he's still alive.
He must be alive.
He's retired down in Suffolk. He's a beekeeper. And our theory is he's using that royal jelly. That royal jelly is keeping him alive.
That must be it.
Yes.
All right.
Prove me wrong. There's a PBS program that's been on at least twice. It's entitled How Sherlock Changed the World. After the stories came out, it changed criminal deduction. It changed how medicine looks at things. They interview the head of a forensics lab in a major city, and she says she never goes to a crime scene without a magnifying glass. That's her first thing she uses.
I really think about the deductive reasoning and analysis that is required of a physician to make that correct diagnosis.
Yes. For example, one of the stories involved a dog that didn't bark at night.
Now, that's unusual
Yes.
because most dogs do bark.
But that was a clue, yes. And that
was the clue.
So that made him think, okay, why didn't that dog bark?
In fact, the beginning of the story of the Sign of Four.
Yes.
The first
story.
He meets Watson and he says, you are from the war.
You're a military veteran, wounded, you're in Afghanistan, and he rattles off a bunch of stuff, and Watson is just
Dumbfounded.
And then later Holmes explains, well, it's obvious, he says to him, you had a deep tan, so you came from the tropics. Your demeanor showed you're probably military, probably an officer. And you walked with a limp, so I tell you were probably wounded. And
that had got you off the war, and you've just...
Yeah. And so when he laid everything out, I said, oh, of course that makes sense. Of Sherlock, which is in modern times, Benedict Cumberbatch.
Yes.
And what's interesting is who'd have thunk, 100-some years after the stories were written, that the Brits would be back in Afghanistan, and you'd have a wounded Dr. Watson.
There it is. This is your show. Your questions are key to our show discussion. We need your call in. Please give us your calls about Sherlock Holmes, any comments or an unusual medical diagnosis that you have. Or, and if you've got an unknown, give me the hint what it is and I'll hang these people.
To dry.
See if we can stump the professors. That's what it's all about. So the professors. So I have a case. So this is a middle-aged man. He had a developmental disability. He loved to hike in the Georgia woods. And his sister brought him in because he never complained. You know, he was quite significantly developmentally disabled. He came into the outpatient clinic, and you know, you're seeing him fast because they're piled outside the room. And he had rigors, or rigors, however you want to call it. I mean, shake and chills. He had aches all over. His neck was maybe stiff. It's one of those deals. Everything was stiff. He had a rash. He had abdominal pain and vomiting. The rash was pink and not palpable. And I asked him if he'd been bitten by any ticks. He said, yeah, lots of ticks. Lots of ticks. Dog had lots of ticks. So, what did I do next? Pete.
Lyme disease, a serologic test for Lyme disease.
Okay, so Lyme disease is what?
Lyme disease is a tick-borne illness, usually from the deer tick. And I can't remember the name of the critter that causes it, but it's a bug.
Yep, Ixodes damini is the tick, and it's endemic for Georgia and all the way up to Minnesota. Not in South Dakota yet, we don't think, although New England in particular. Bob, what do you think the next test should be?
So if he's in Georgia, the next test should be giving him doxycycline and then running tests because he probably has a tick-borne illness, and they almost all respond to doxycycline. It sounds like Rocky Mountain spotted fever because of the rash. It could be ehrlichiosis, and so I would do serological testing for that. But in the meantime, I'd put him on doxycycline. I'd get blood cultures just to make sure it's not something else.
Right, with the rigor.
You're not just fooling me with him being hiking in the woods.
Yeah, well, and you know what? With the rigors, I'd also cover him for gram positives, and that's what we did. But I will tell you this, that it was in 1976. So it's not likely Lyme disease at that time, or if it was, we didn't know it. So the idea that it was possible Rocky Mountain spotted fever. Now, where's the most common places of Rocky Mountain spotted fever?
It's actually the southeast. It's not the Rocky Mountains.
It's not the Rocky Mountains.
Right.
That's right.
But Ricketts was in the Rocky Mountains when he found the bug.
Yep, he did. And is it endemic in South Dakota, Pete?
I don't know.
It is. It's here. We've seen it. I've not seen a lot of cases. I've not seen any cases, but it is endemic in South Dakota. The man was started on doxycycline and Rocephin, or Ancef, I think at the time, and the man came out of it, got much better, and the tests for Rocky Mountain spotted fever were positive. Very good.
One for the internist.
Yes, for a brand new internist. That's what it was. A woman from Watertown asked, what kind of tests do physicians do to determine if a patient has stomach cancer? Pete.
Well, probably the simplest clue to that is bleeding, which you'll detect with a hemocult,
yes.
A stool test for blood. That's very non-specific, of course, because the bleeding could occur anywhere in the
GI tract.
GI tract. As always, a careful clinical history is sometimes going to give you a clue about where the tumor might be.
I think the history is the most important part of any diagnostic testing.
And we pathologists actually agree with that. Jumping right into Lyme disease was one thing, but Bob was certainly correct. You take care of the patient first, and then figure out the details.
Right.
So in this case. A careful clinical history. If it indicated that there was something wrong in the stomach, then probably the best thing to do would be gastroscopy with a long tube inserted down through the esophagus and into the stomach to take a look, and perhaps biopsy or take cytology specimens.
So please call 1-888-376-6225. I see that on the prompter. I'm glad that we're seeing that. We need your questions. We have another one. What is the most interesting confounding cases that you've encountered in your career, Bob?
The most interesting confounding case, there's so many. It's really hard to pick one particular one. I can tell you a really fascinating case that I saw in 1976, since you brought up 1976. which just goes to show we're approximately the same age.
Yeah.
I was a second-year resident, and this man got admitted to the VA for some vague chest pain. He went down for a stress test, and in 1976, a stress test was you got on a treadmill and you walked. They couldn't do the stress test, and it was only an EKG test. And they couldn't do it because his pulse was 120, 125. He comes back. The intern had seen him the night before. I said, why is he so tachycardic? Why is his pulse so fast? And he said, well, he's had increased ileal output. So this man actually had a bag. He'd had his colon removed while he was in the service. This was a VA patient. And instead of normally, if you have stuff coming out of the ileum, it's about a half a liter a day. He had 5 liters a day coming out. And that had been going on and gotten worse over the past month.
So diarrhea.
So he had diarrhea, real significant diarrhea. In addition to that, he had a calcium of 12.5.
Elevated.
And we had no idea what the hell was going on.
Okay, Pete. Elevated calcium, profound diarrhea. In a middle-aged man, did you say, Bob?
Yeah, 50-year-old postal worker. And no one had ever gone postal at that point.
Okay, yeah.
It was 1976. It was before postal.
So did he have one of these endocrine tumors that causes excessive peristalsis, and it was an endocrine kind of a
So
tumor?
he did not have a VIPoma. He did not have Zollinger-Ellison syndrome. Those would be 2 possibilities. But that neither one of those would explain the high calcium. And that was really...
Hyperparathyroid, of course.
Well, you'd have to, you would start, like Holmes would do, probably start with something that you know. You know 2 things. He's got severe diarrhea and he's got hypercalcemia. So what are the causes of those independently, and do any of them overlap?
Right.
So milk alkali syndrome would certainly be one of the things that might
Which
be
is what?
associated with both.
Drinking too much.
The intake is too much calcium in it, and usually with antacids.
Yeah, the milk of magnesia or the Maalox and Mylana type of a thing.
No, it was actually Tums. So you might remember this, Rick. There was a diet called the Sippy diet. And the reason it's called the Sippy diet was Dr. Sippy, who was a surgeon. Mm-hmm. And that was how we treated ulcers in the 1970s before you go to surgery. And the reason they called milk alkali is they told you to drink milk 6 times a day with small meals and take Tums.
Nailed it.
Yeah. So is this score 1 for the pathologist?
Well, it's good that you got that.
You
got it. I missed it.
Yeah. So I actually use this as a teaching case over and over again, and the only way you can possibly get to the answer is to list everything that causes hypercalcemia and then see if any of them cause diarrhea. Mm-hmm. And so this is probably about the 7th or 8th or 9th thing on the list of what causes hypercalcemia. Just
read them off in your brain as fast as you can, aside from hyperparathyroid, thyroid disease.
There's four ways cancer can do it.
Yep.
So everybody thinks about cancer. There's sarcoidosis, and everybody says, well, he had Crohn's disease before, could have sarcoid. But you got it right. He had hyperthyroidism.
All right. Very good. Doctors often use clues to help diagnose diseases. Clues are also used to investigate outbreaks and epidemics. A physician journalist and CNN medical analyst recently visited the South Dakota State University campus and explained what it's like to be a disease detective.
Being a disease detective is a really exhilarating job because you get deployed, sometimes at really short notice, to anywhere that there could be an outbreak of any possible thing. And oftentimes when you arrive, you're one of the first officials on the scene, and you may not even know what is making people sick. All you may have been told is, go to this area, there have been 6 deaths in the same community, or go to this area, 24 people suddenly have a bright red rash. So you go with often very little information, and it's your job to build trust with people, even when they're really panicking and they're sick, and to get as much information as you can to try and piece together all the different parts of a jigsaw puzzle to figure out what's making these people sick and how you can stop it.
You're currently exploring the way that news spreads during epidemics. During a public health crisis, how might we limit the spread of misinformation?
So I'm currently a John S. Knight Fellow at Stanford University, investigating not just the way that diseases spread during an epidemic, but how misinformation about diseases spreads during an epidemic. We've seen that contagions have the ability to impact communities in really powerful ways. We've seen even in the last few years that an epidemic can impact a society's economy. It can impact the way people communicate with their neighbors, the way that they travel. So I'm really interested in how news spreads and how we can keep people safe, not just by stopping the disease, but stopping any rumors and any pseudoscience about the disease as well.
And how do you think we could actually do that?
I don't know yet. And that's why I'm at Stanford, surrounded by very, very clever people who are from very different backgrounds, computer scientists and economists, trying to figure out how does a rumor spread when you have a huge Ebola outbreak, and what could we do in the future, because we know we'll always have more outbreaks. So what could we do in the future to detect those rumors early on and almost kind of vaccinate against them, so, stop them in their tracks, stop them spreading.
We want your questions. Thank you for calling them in. A man from Brookings asked, do you interact with law enforcement in your everyday career? If so, what are some of the best memories with law enforcement? Now that's very interesting. Bob, I'll start with you.
I avoid law enforcement every time I can, and it just doesn't come up. It just doesn't come up.
It's frequent for pathologists. You forensic autopsies. There's not always a forensic pathologist around, one specifically trained in forensic pathology. So a general pathologist will end up doing the case for law enforcement. So it's a common interaction, and often to provide some insight that changes the officer's opinion of the course of events is one of the things that is probably most satisfying about those interactions.
And generally that's a positive interaction.
Yes, it is, always.
I have had interactions with many great police officers, particularly with patients that are psychiatrically involved. But my wife was the county coroner, and I was her assistant for 10 years. I mean, it was a really interesting. She's a pediatric nurse practitioner. Makes no sense at all, but I mean, she was willing to do it.
And I was the recipient of some of her calls, all of which seemed to occur after 10 at night.
Yeah, that's when those dead bodies come rolling in, sometimes, and you don't know why it happened. And trying to find a way to get an autopsy is a question, and sometimes the sheriff department doesn't want an autopsy because it costs money and they're dead and there's no reason to think that there could be foul play. But as the physician, I think when we don't know, we want to have an autopsy.
Yeah, and very often that not only helps law enforcement, it also helps the families, because there's always something there to discover.
Right. So here is a positive word for police officers whose hearts seem most of the time very much in the right place.
Oh, they are.
And there are probably bad doctors and bad police officers and bad teachers, and in all of those groups. And it's just that that they make the rest of us have to jump through too many hoops.
That's true.
Afraid. So we have a case of a patient who came into my office and was a little overweight, not uncommon problem. Her blood pressure was high, not an uncommon problem. She was an emotionally distressed person, not an uncommon problem. I had a clue that she had a kind of a fat disposition that was unusual, a little bit of heaviness on the shoulders. Her skin appeared thin, and she had a redness to her face. So what should I do next? Bob?
Yeah, you want to check her steroid levels. I think it'd be a urine test and test her cortisol and see if first do a blood cortisol randomly and see if it's high, and then show that it really doesn't stimulate. You're probably talking about Cushing's disease, and if in fact she has a high cortisol level, you're going to look for a tumor in the adrenal glands.
Right. Pete?
I would agree with that. And most of the tumors in the adrenal that cause symptoms, most of those, it's 50-50 whether or not they're malignant.
Right, and so these tumors of the adrenal gland do happen, and they put out too much prednisone equivalent, or the steroid, and then they have all of the manifestations of too much steroid.
Yes.
Did she have diabetes also?
She had diabetes. She had hypertension. I forgot to add that. It's on my list. And the interesting part of it is that I sent her to an endocrinologist, and I said the Cushing, the cortisol level and the urine level and the suppressions some of them were not perfect, but it looked significantly like Cushing's in every other way. And the endocrinologist said, no, not it. And we waited another 6 months, and her problems worsened. And she elected to have me send her to the Mayo, at which time they nailed it. And they took her to major surgery, removed the tumor of the adrenal gland. She lost 100 pounds of weight. Her blood pressure normalized. We had to replace her prednisone, her steroid, with prednisone for a long period of time and just gradually bring it down. Mm-hmm. But she was really a real case of Cushing syndrome. Bob, have you seen, I know that in a university hospital you must see these.
Well, I actually have been working mostly in the community hospital, but when I was an intern, the clerk in the coronary care unit developed Cushing syndrome in front of the entire house staff, and nobody recognized it for about 9 months. It's, if you've been taking care of someone for a long time and they just slowly get worse, for you to pick it up is really great. But I have a great adrenal tumor story to tell you.
Let's hear it.
So this undocumented worker in North Alabama comes in to the hospital with the acute onset of quadriparesis. Quadriparesis is he can't move any muscles.
Right.
Yesterday he's working in the fields. Today he can't move anything. His potassium level's 1.2.
I mean, that's really, really, really low. I mean, that's just profoundly low hypokalemia.
Right. And profoundly low hypokalemia will make your muscles not work. We gave him potassium, and he could move again, which made him very happy. His bicarbonate level was like 35, and he had significant hypertension. So he had a different tumor. So I'll let you get that one, Rick.
So it's hypokalemic alkalosis. It's an aldosterone case, and it's an adrenal tumor that makes too much aldosterone.
Right. He made too much aldosterone. We sent him to the university hospital, and they took out his tumor, and it cured his hypertension, and he didn't have paralysis again.
So that same patient presents to my office, a man from Turkey, traveling, and presents hypokalemic alkalosis, low potassium, and of course, you guys know what I'm looking for. We did a CAT scan. That adrenal tumor was not there, but the man had severe hypertension, and he presented with this hypokalemic alkalosis. Peter?
Puzzled.
Bob?
There are a couple things. So he could have an inherited disease. There's a disease called Gittleman's that might present like that. Or he might be a licorice aficionado.
Yes, he's a Turkish licorice eater. And within the licorice he's been eating, of course, has the glycyrrhizinic acid, which is the same thing as the aldosterone, or aldosterone, depending upon how you want to say it. And to cause this hypokalemia. Great. Wonderful. Okay, we have a question. A man from Brookings asks, do you interact? A woman from Rapid asks, can you explain what C. difficile is and what causes it and how do you treat it? Pete?
Well, Clostridium difficile is an organism that occurs or can in the gut. It can overgrow the gut and produce a diarrheal illness. The mainstay used to be antibiotics, but quite frankly, today we do fecal transplants. They're cheap, they're effective, and they're not commonly used.
Right. Now, this person with C. difficile comes in, and first question I ask is, have you been on antibiotics in the last 3 months? And the patient says no. Bob?
So there is spontaneous C. difficile, but one of my favorite mystery characters is a guy named Harry Bosch. The author is Michael Connelly, and in one of his books, he says, you ask the question, and if you don't like the answer, you go back and ask the question again. And this is a true story. I had a young woman come in who we diagnosed with C. difficile diarrhea. And I have the entire team around me. I have the resident, 2 interns, 2 medical students. I asked the patient, has she ever been on any antibiotics? She'd never been on any antibiotics. And so we went out and talked about how you can just get C. difficile in the community. The next day I come in and the resident said she forgot that she'd been on ciprofloxacin. So the first thing I do is I ask again, have they taken any antibiotics for any reason? That would be the most common reason you get C. difficile is you have an antibiotic, and that antibiotic kills the good bugs. Remember, if the audience has read about the microbiome, the colon and the intestines have many bacteria in it, and we live sort of in a symbiosis with those bacteria. And the problem is if you kill the good bacteria, the C. difficile overgrows, as was said earlier, and that can cause diarrhea. So the second person to take the history usually gets better history. Usually that's the teaching attending physician goes in and gets the brilliant answer that the interns and residents didn't get, because all the patients thought about for the last 8 hours is the answers to these questions. But in this case, the resident trumped me and found out that she'd actually taken antibiotics. So that's the first thing I do is go back.
I love the importance. Yes, I love the value of taking a history and taking a good history. I remember a case. I was the resident attending. I was catching. So the patient was being admitted in the emergency room to me and my service. I had 2 interns and 2 med students working with me. I'm the junior resident up on the medical floor. And I was told I had to come down and pick up a patient with chest pain. Patient had been evaluated in the emergency room. I didn't question the admitting doctor, and I said to this younger woman, something like 35 and thin and anxious, what kind of pain you have? Well, I'm kind of having chest pain. Well, where in the chest? Well, I don't know. I mean, it was, what makes it worse? Well, maybe if I take a deep breath, maybe. Whatever it was. And I led a few questions, is it made worse if you move? Is it made worse if you change position? What makes it worse and what makes it better? And I got the history, and it was a diffuse, non-specific. She's not having a heart attack. The EKG was normal, but he's admitting because she's having chest pain. And I said, you're going to have a med student talk to you, an intern talk to you, and then you're going to have the fellow cardiology talk to you. And so the next morning, after she was seen by all 3, I said, now what was that pain like again? She said, I'm having a crushing substernal chest pain. It's radiating down my arm and into my neck. She read the book. She read the book. She was taught by the resident and the interns about the pain. We have a case of a person who presented with lesions on the hands, some sores on the mouth, college student, and there's an epidemic of I want to say, hand, foot, and mouth disease that's going on. I mean, in the pediatric world, under 10, everybody seems to be having it. Kid has a younger sibling at home, and he's got the picture of hand, foot, and mouth disease. What else could cause such a symptom of purpura spots, kind of almost vesicular on the hands in a college youth? Bob?
Is back of the hands or the palms?
It seemed to be the back of the hands, actually, the back of the hands.
Back of the hands, not the palms. Okay, that makes a difference, because if it was the palms, you'd think about syphilis.
Actually, it was the palms.
So you think about syphilis and Rocky Mountain spotted fever.
And the man said to the doctor who went into the room to see him, he said, "You think I could?" She said, "I think you have hand, foot, and mouth disease." And he said, "Could I have syphilis?" And she said, "Yes, it could be," and checked him out, and he did. It reminds me of the brilliant diagnosis I made one day. Man and woman are in the room, and the gentleman is there. He's kind of a round fellow. He's a trucker, and his blood pressure's been high, and I'm struggling with that diagnosis. And the wife said, "Doctor, do you think he could have sleep apnea?" And I said, do you snore loud?" She says, "He really snores, and I can hear him have episodes of apnea. And he's sleepy during the day." Mm-hmm. He goes, "Yes." He agreed in everything that she told me, because she told me the whole story. And of course, he had sleep apnea.
Of course.
Brilliant diagnosis.
Of course.
So Rick,
Yes.
I have a great quote from you, because you were quoting Sherlock Holmes before, and I use this quote in my talks a lot, and it'd be interesting to see what both of you think about this. This is from the second episode of the BBC series with Benedict Cumberbatch.
Okay.
And so he's in a room, and a junior detective is telling him the answer to the puzzle, and he keeps asking him questions, and the guy said, "That's not important, that's not important." And he then says, "You have a solution that you like, but you're choosing to ignore anything that doesn't comply with it."
Yeah. That's exactly it. Do you understand what he just said?
Well, yeah, it's
very quickly.
It's a foreclosure of the exploration of the illness.
Yeah, you're done looking. You're
Yeah.
done thinking. I've got two questions, but any more comment about that, Bob?
Well, I just think it's one of the most important things. Whenever I make a mistake, that's usually the reason I make a mistake, is I don't pay attention to a clue. And that's where Sherlock Holmes, and not just reading Sherlock Holmes and watching the shows about Sherlock, but all mystery books really help us, reminds us not to ignore clues. That's usually when you're reading a mystery novel, there's a clue there that everybody is overlooking except for the brilliant detective.
So we've got two more questions, and we don't have time to answer them, but if you go to the internet, the answers will be there. And now for the winner of tonight's Prairie Doc quiz question, true or false? The stories penned by Arthur Conan Doyle about Sherlock, Dr. Sir Arthur Conan Doyle about Sherlock Holmes during the period 1880 through 14 describes a private detective and best friend, Doc Watson, narrator of the stories, and the answer is false. Holmes referred to himself as a consulting detective, not a private detective. It was Marilyn First from the Wessington Springs area who answered the question correctly. Thank you, Marilyn, for participating, and a book will be in the mail to you soon. We'll be right back after this.
Because they want you to be there for the many milestones yet to come. Because you don't want to miss out on the little things. There are many reasons to get life-saving cancer screenings. 1 in 8 women will be diagnosed with breast cancer in her lifetime. But regular self-exams and mammograms can catch it early when it's most treatable.
Promise?
Promise. 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 Promise.
Make the promise to get screened. Do it for the people you love. For more information about life-saving screenings or available financial assistance, visit getscreenedsd.org.
Stories of curiosity, mystery, and murder invented or real, have fascinated people for many years. The first in this genre, the invented tale of Frankenstein's monster, was first published in 1818. During author Mary Shelley's life, the study of anatomy was advancing, but there was difficulty obtaining bodies for dissection. The grim solution came from grave robbing. Shelley's story evolves with scientist Frankenstein searching for dead body parts, although his purpose was not for the study of anatomy. He pondered, "The moon gazed on my midnight labors, and who shall conceive the horrors of my secret toil as I dabbled among the unhallowed damps of the grave? I collected bones with profane fingers, where death had apparently devoted the body to corruption." 10 years later, a true story also highlighted the difficulty of finding human bodies for dissection. Dr. Robert Knox, a Scottish anatomist at Edinburgh University, was desperate for bodies to dissect in teaching anatomy. A lodging keeper, William Hare, had a tenant pass away who owed Hare money. Understandably, Mr. Hare sought to clear the tenant's debt by selling the body to Knox's anatomy lab and received the surprisingly large payment of about $800 in today's money. After that, Mr. Hare, with his friend Thomas Burke, began murdering the working class people living in or near Hare's boarding house. Over the next 10 months, the bodies of 15 others were sold to the unsuspecting Knox. The jig was up when Mrs. Gray, another tenant, noted Burke acting suspiciously, and her curiosity prompted a search after Burke left the hotel. Indeed, Mrs. Gray found a dead body and called the police. After careful investigation, multiple murders became evident. Dr. Knox convinced the jury he didn't know of the murders, but lost his job. Hare was granted immunity for spilling the beans, but had to escape the country. Burke became the fall guy, was hung, and his body was dissected in front of a crowd. His skeleton is still on display in the Anatomical Museum of Edinburgh. Wow, a true and intriguing story demonstrating greed, murder, and the gruesome justice that followed. 12 years later, the American writer Edgar Allan Poe wrote the first detective story, The Murders in the Rue Morgue. And some 46 years after that, British author Arthur Conan Doyle began writing about the brilliant detective Sherlock Holmes. Both authors frightened their readers with invented and gruesome tales. Stories of curiosity, mystery, and murder, invented or real, have and will continue to fascinate and captivate audiences for many years to come. Well, a great big thank you to our guests. You know, they didn't know, and I didn't know what this show would do tonight. Yeah, but it was great. I loved it.
We had a ball.
Dr. Henry Travers, Dr. Robert Centor, their insights raised the level of our discussion to great heights. Thank you both. So, well, it's that time of the year again. The flu season is arriving. Getting your shot now will give you the best protection during the coming months. South Dakota usually has one of the highest vaccination rates. Let's keep that good record going and beat Alabama in particular. And there is an event to recognize the fight against pancreatic cancer. It's the 2017 Light the Capitol Purple ceremony on Sunday, October 29th at 3 p.m. on the Capitol Rotunda and Pier. We'd encourage anyone who can to attend. Well, that does it for tonight from all of us here at On Call with the Prairie Doc. Until next time, stay healthy out there, people.
The ever-changing and intriguing treatments for a terrible disease, breast cancer and precision oncology. Next time, On Call with the Prairie Doc.
Major funding for On Call with the Prairie Doc has been provided by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On-Call television as it continues to open doors for important medical information.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. And with the ongoing support of these individuals and institutions, Brookings Health System Ophthalmology Limited, Avera Heart Hospital, Dakota Allergy and Asthma, Fishback Financial Corporation, Vance Thompson Vision, Aberdeen District Medical Society, Black Hills Medical Society, 3rd District Medical Society, Brookings, Madison, and Flandreau, Dakota Bank, Orthopedic Institute, Physicians Care, Sanford Clinic Community Service Committee, and Swiftel Communication.